Langsung berdiri. Dokter yang lain boleh dibantu? Would you mind to stand up? We are going to do a little warming up. Ya, kita mau warming up. Biar rasa kantuk yang sudah melanda ini go away begitu ya. Oke. Biar jadi tenaga dokter ya. Oke, para dokter yang di sebelah sini boleh saya minta bantuannya nggak untuk bisa bangkit berdiri? Kita mau warming up sebentar aja. Enggak, warming upnya enggak SKJ dok. Kalau SKJ 96 itu dulu SD ya dokter ya. Oke, boleh dibantu, masih menikmati, boleh dibantu bangkit berdiri. Baik, luar biasa. Nah, warming upnya gampang saja para dokter sekalian. Nanti saya akan mengucapkan kata optik tunggal, kemudian para dokter akan menjawab, tapi jangan lupa gerakannya juga ya. Best choice, tetap ini, best service, best quality. Oke, boleh? Let's give it a try, oke? Ready ya? Oke, tunggu. Best choice, gini deh ke depan, best choice, best service, best quality. Yes, I love your spirit, dokter. Oke, kita coba optik tunggal. Best choice, best service, quality. One more time, optik tunggal. Best choice, best service, best quality. Boleh kita berikan tepuk tangan. Thank you so much. You may be seated. Silahkan untuk para dokter boleh kembali. Belum panas ya? Nanti dokter ya. Nanti di malam, acara malam kita panaskan restoran 360. Baik, kita akan kembali melanjutkan untuk agenda selanjutnya dan memasuki sesi yang ketiga dengan judul Dry Eye and Corneal Aberration in Premium Cataract Surgery. Dan untuk itu kembali saya mengundang kepada moderator Dr. Ria Sandi Deneska, spesialis mata and konsultan, untuk bisa naik ke atas panggung. Waktu dan tempat saya persilahkan.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang. Dengan saya lagi, mohon maaf. Kita lanjutkan sesi ketiga yang tidak kalah penting dengan topik-topik sebelumnya. Semoga masih bersemangat, ini jam kritis. Kita akan ada 4 pembicara yang menyampaikan materinya. Kami persilahkan kepada para pembicara untuk naik ke panggung bersama saya. Please, all the speaker to come to the stage with me. Presentasi pertama akan disampaikan oleh Dr. Christina Tan dengan judul Advancement and Premium Cataract Surgery and Dry Eye Management. Dr. Mungkin bisa ditayangkan CV dari Dr. Christina Tan. Beliau adalah dokter mata, konsultan kornea dan refractive surgery di Manila. Okay. Slide untuk beliau sudah siap? Dr. Christina Angelica Tan, please, time is yours.
Okay, hi. Good afternoon, everyone. So I'm Dr. Christina Tan from the Philippines. My institution is the Medical City in Manila, Philippines. Okay, so as we know, next slide, please. So as we know, we need a good screening protocol to achieve good post-op results. Eye surgeons today are not just cataract surgeons, we are also refractive surgeons as well. So our patients do expect good outcomes from us, and so the optimization of the ocular surface is very important to achieving better outcomes. So optimizing the ocular surface leads to improved surgical outcomes, as accuracy of your pre-op measurements, such as keratometry, are dependent on this. So a good pre-op screening reduces post-operative complications such as bad visual outcomes, and this increases patient satisfaction. So as we mentioned, next slide, corneal surface irregularities lead to inaccuracies in keratometry measurements, inaccuracies in axis calculation, and wavefront analysis. So this again affects patients' overall satisfaction with the procedure that we do. Next slide. As we do know, dry eye plays a very important role for ocular surface disease. So diagnosing dry eye is crucial in pre-op cataract screening. So just to recap, there are two schools of thought regarding dry eye, namely the TFOS DUCE 2, or the Dry Eye Workshop, and the ADs, or the Dry Eye Society. So both DUCE 2 and the ADs offer different perspectives on dry eye diagnosis and management. So DUCE 2 approaches tear film homeostasis. So it includes tear film instability, hyperosmolarity, ocular surface inflammation, and neurosensory abnormalities. It employs a more diagnostic and broader approach, including symptoms, non-invasive breakup time of less than 10 seconds, osmolarity of more than 308, and ocular surface staining. On the other hand, you have ADs, which emphasizes tear film instability as the central cause for your dry eye. So it uses tear breakup time as the key diagnostic tool, with T-BUT of less than 5 seconds as the criteria for an unstable tear film, plus your symptoms. Next slide. So a comprehensive dry eye evaluation is crucial prior to cataract surgery to optimize ocular surface health and again minimize post-operative complications. So this is the dry eye protocol that we are currently using in our refractive center at the Medical City, Philippines. So doctors in our hospital send their premium cataract patients to us for dry eye screening, and we advise them on how to manage their dry eye for the surgical procedure. So we use the OSDI questionnaire, as you can see here. Then we use diagnostics, mainly the Oculus Keratograph 5M via the GenVis Pro report, and we also use Schirmer's test and tear osmolarity. Our treatment is based on the tear film-oriented diagnosis, which focuses on understanding dynamics and breakup patterns of the tear film. So dry eye is classified into 3 subtypes, which are aqueous deficiency dry eye, decreased wettability dry eye, and increased evaporative dry eye. Next slide, please. So just to give a brief background, the Oculus Keratograph 5M is a corneal topographer with keratometer and a camera optimized for external imaging. So it uses placido ring illumination to measure the whole corneal surface, and a white ring illumination is used for tear film dynamics. The blue illumination ring is used for fluorescein imaging, and the infrared ring is used for mammography as well as tear film analysis. So here's the summary of the tests that we use for dry eyes, starting with the OSDI dry eye questionnaire. We also assess the tear film, including tear meniscus height, NIC-BUT, tear breakup time, and interferometry. Next slide. We then assess the lid margins, starting with meibomian gland orifices, telangiectasia, and mammography. And finally, the conjunctiva is assessed for bulbar redness, as well as conjunctival and corneal staining. Next slide. So this is what the parameters will look like in the GenVis Pro Dry Eye report, and we will be discussing one by one in the upcoming slides. So starting again with the ocular surface disease index, this is a 12-point or 12-item questionnaire which we use to assess dry eye symptoms and their impact on vision-related activities. Next slide. So an OSDI helps classify the severity of dry eye symptoms. Next slide, please. Okay. So the OSDI helps classify the severity of dry eye symptoms with a score of 0 to 12 indicating no or minimal symptoms, 13 to 22 suggesting mild dry eye symptoms, 23 to 32 suggesting moderate dry eye symptoms, and 33 to 100 suggesting severe dry eye symptoms. So in the keratograph, you will see the total score at the bottom left of the screen. So next slide. So going to tear film parameters, the tear meniscus height is measured via the distance between the lower eyelid's edge and the tear strip. So a value of less than 0.2 millimeters is indicative of your dry eye disease. So next slide. Here's the quantitative classification for tear meniscus height with grading of very high to very low tear meniscus height, again with less than 0.2 millimeters being suggestive of dry eye disease. So next slide. The NICBUT, which stands for non-invasive keratograph breakup time, as the term suggests, is a non-invasive alternative to your tear breakup time. So the keratograph will use your infrared illumination to visualize the tear film on the cornea, and this can identify and track areas where the tear film breaks down, and it measures the time it takes for this to occur. So this is used to assess for tear film instability. Next slide. So, next slide, please. So I'm showing a diagram of the tear film and how breakup occurs. So in normal healthy eyes, the tear film is released from the glands and it's pushed out by the blink reflex. And the tear film spreads out and begins to evaporate, which is called the tear breakup time. So if the tear film breakup occurs quickly before the blink, then the dry spots appear on the corneal surface. So breakup can be observed either as dark spots on your fluorescein staining or by distorted Meyers in the Placido ring illumination. Next slide, please. So tear film breakup or tear film destabilization can also be seen as wave-like distortions on the Placido ring illumination. Next slide. Again, tear breakup is seen as distortions in the Meyers, as we see here encircled below in the pictures below. Next slide. So NICBUT is quantitatively graded based on the time it takes for the breakup to occur, and grading is from above average to very short tear breakup times. Next slide. So the keratograph will also give you a diagram on how fast tear breakup occurs, which gives you easy visualization of the breakup times. So green areas would mean longer breakup times, while shorter areas or shorter breakup times would appear as orange to red areas. So grading is from level 0 to 2, with 0 being average and level 2 being very short. Next slide. So here the next parameter, if you can play the video, okay. So the next parameter in the tear film assessment is interferometry, which assesses the lipid layer of the tear film. So the thickness of the lipid layer is a key indicator of tear film stability and evaporation. Next slide. So here we have, next slide please. Interferometry that is qualitatively graded based on the color of the tear film. So you can see that a reddish bluish to yellowish hue would suggest high lipid abundance and lipid equilibrium, as opposed to a white grayish pale hue which suggests a lipid deficit. So of course this is more qualitative in nature, and sometimes it does not correlate to other parameters such as your OSDI or mammography. Next slide. So as we mentioned earlier, a thick lipid layer suggests for better lipid equilibrium in comparison to a thinner lipid layer. Next slide. So we do also use Schirmers to assess tear production, and measurement of more than or equal to 15 is normal. We do have a measurement of 6 to 14 as slightly dry eye, and less than or equal to 5 as dry eye. Okay, next slide, please. So here are the summary of tear film assessment as previously discussed. These are the parameters that we would like to see for tear film assessment. Next slide. So moving on to the lid and its margins, we first assess the meibomian gland orifices. So it is necessary to assess the structure of the meibomian glands, as an abnormality of the meibomian glands would lead to meibomian gland dysfunction, which is a major cause of your evaporative dry eye. So this can result in ocular discomfort, eye irritation, inflammation, and ocular surface disease. So the key to the diagnosis of MGD is the ability to evaluate the meibomian glands and the lipid layer. Next slide, please. So grading is again qualitatively based on the degree of plugging from normal to severe. Next slide. So next, lid margin telangiectasia is also a parameter which is used to assess for inflammation. Next slide. So grading is also qualitative based on the severity of telangiectasia as seen in the lid margins. Next slide. Lastly, for lids, we look at the meibography, which is done to evaluate meibomian gland dropout and health. Next slide. So we see here grading from 0 to 3 based on the percentage of dropout. A grading of 1 would suggest less than 33% dropout. Grade 2 is around 33 to 67% dropout, and grade 3 is more than 67% dropout. Next slide. Here's a summary for lid margin assessment, and these are the following signs that you need to look out for. For lid margin, you need to see telangiectasia, notching, scalloping, saponification, palpebral concretions. For lashes, the presence of crusting is a sign. Telangiectasia, you'd see rosacea, hyperemia, edema. And for meibography, you'd see dropout with shortening, truncation, and tortuosity of the glands. Next slide, please. So now we move on to conjunctival assessment, starting with conjunctival redness. So the keratograph automatically detects the amount of conjunctival hyperemia, which is a sign of ocular surface inflammation and irritation. So next slide. Comparison of the detected redness is done with a GenVis grading scale from 0 to 4 based on the amount of redness that is seen on the screen. Next slide. Conjunctival and corneal staining is another qualitative assessment of inflammation, which with increased staining as a sign of inflammation. Next slide. Okay, so qualitative severity is graded from 0 to 4 based on the amount of corneal and conjunctival staining that you can see. Next slide. So the tear film-oriented diagnosis of dry eye can be done via video documentation with fluorescein staining. So in our center, TFOD is used to diagnose the type of dry eye to guide treatment plans. So there are 5 breakup patterns corresponding to aqueous deficiency, decreased wettability, and increased evaporative dry eye. Next slide. Here's the summary for corneal and conjunctival assessment. Next slide. And finally, for all parameters, it will be summarized in the GenVis Pro Dry Eye Report, which provides you an overview of the condition of the entire ocular surface. So it allows you to see which parameters on the ocular surface are affected, and this display is given to your patients so you can advise them on treatment options based on the result of their keratograph. Next slide. So we do use in our center the tear film-oriented therapy, which is focused on stabilizing the tear film to treat dry eye. So it's a layer-by-layer approach. You identify and address specific deficiencies within the tear film layers. So it's either the aqueous, lipid, or mucin layers, or combined to improve the tear film stability and ocular surface health. So it also includes anti-inflammatory treatments such as your corticosteroids and immunosuppressants to treat ocular surface inflammation. Next slide, please. So just go through this quickly. I'll show you several cases of dry eye that we have seen in our center. So next slide. So case 1 was a 58-year-old male who came into the center for blurring of vision and foreign body sensation. So assessment was presenile cataracts with pterygium on both eyes. On the right, more than the left, and the attending physician's plan was to do phacoemulsification with IOL implant. Next slide. So our plan was pre-op screening, which includes dry eye evaluation with a keratograph 5M with OSDI, Schirmer's, and tear osmolarity. Next slide. Okay, so as you see here, OSDI was 75. Next, can you click again? Another one. Okay. So OSDI was severe at 75, indicating that the patient was symptomatic with daily activities affected, and mild dryness and inflammation was seen for Schirmer's and tear osmolarity respectively. Next slide. So gross examination would reveal the presence of pterygium on both eyes, right more than the left. So as you see on the right eye, the Meyers are distorted nasally, again indicating the irregularity caused by the pterygium. So I also included corneal tomography to show how the pterygium causes irregularities on the corneal surface, which definitely affects pre-op biometry measurements. So tomography on the right shows flattening of the nasal area, which is consistent with pterygium location, and moderate astigmatism with a slightly irregular corneal surface. So the pterygium on the left is a lot smaller than the right, which has less effect on the corneal surface. Next slide. So on mammography, we do have dropout on the upper lids more than the lower ones, with an average grading of MGD of 2. So mild to moderate plugging is also seen on the meibomian glands for both eyes, as seen in the lower picture. Next slide. So bulbar redness was mild to moderate for both eyes, and the tear film-oriented diagnosis showed for the right line break with rapid expansion and occasional spot break. Could you play the video? Okay. So the right eye shows line break with rapid expansion and occasional spot break, and for the left eye, a random break with spot break. So you can also observe how the tear film is unstable in the right eye due to the presence of the pterygium nasally, and tear film instability is also present on the left. Next slide. So here's the summary of the parameters, and based on TFOD, the patient was assessed as decreased wettability, evaporative dry eye with meibomian gland dysfunction and pterygium bilaterally. So attending physician was advised, the plan was to start patient on diquafosol every 3 hours with sodium hyaluronate in between. We started him on a short course of loteprednol 3 times a day. And we treated the MGD with warm compresses, omega-3 supplements, and IPL with low-level light therapy. Okay, so we also advised the patient for pterygium excision with conjunctival autograft before doing the other tests, because as we know, this will severely affect pre-op measurements such as your keratometry. So we suggested repeat keratograph, 5M, and other cataract tests after pterygium excision and reevaluate. So I personally wait at least 3 months after the surgery to continue the dry eye treatment before performing other diagnostics for more accurate measurements. Next slide, please. So next is a second case, 73-year-old female complaining of blurring of vision for both eyes. She was assessed with senile cataracts and is status post-myopic LASIK. Okay, so plan for this patient was phacoemulsification with multifocal IOLs, both eyes, and since she is post-LASIK with plans of multifocal implants, a thorough dry eye assessment needed to be performed to ensure accurate measurements. So again, we used our dry eye protocol. Next slide. Dry eye evaluation, OSDI, keratograph, Schirmer's test, and tear osmolarity. Next slide. So OSDI again, next please. Another one. Okay, so OSDI showed severe symptomatology, also affecting daily activities such as her driving at night. Mild dryness and inflammation was seen for Schirmer's and tear osmolarity respectively. Next slide. So grossly, you can see that there's only mild redness bilaterally with very minimal Meyer distortion. Corneal tomography was also performed to confirm the presence of laser myopia correction, which is present as central corneal flattening with peripheral steepening. Next slide. Again, there is dropout in mammography for the upper lids more than the lower lids, resulting in grade 2 MGD, and several glands are also plugged bilaterally. Next slide. Can we play the videos? Okay, the TFOD shows random break and spot break for both eyes, and here I'm not sure if you can see it, but you can see a faint outline of the LASIK flap in the periphery. Next slide. So here's the overview for both eyes. Assessment based on TFOD was evaporative and decreased wettability dry eye with MGD and status post-myopic LASIK bilaterally. So dry eye treatment again included diquafosol sodium every 3 hours with sodium hyaluronate, a short course of steroids 3 times a day, and we also treated again the MGD with warm compress, omega-3 supplement, and IPL. So again, we advise for repeat keratograph, 5M and other cataract tests after dry eye treatment, and we advise to reevaluate after. Next slide. So this is the last case that we have. So the patient is a 78-year-old female complaining of foreign body sensation for both eyes. Assessment is primary angle closure glaucoma, status post YAG-LI phacotrab with IOL implants, and she was currently on brimonidine 3 times a day where the IOPs are controlled. So next slide. Plan for this patient again was dry eye evaluation with OSDI, keratograph, Schirmer's test, and osmolarity. Next slide. So this was the old iteration of the GenVis report. The ones that you saw before was the GenVis Pro. This was the old one. So we see here decreased tear meniscus height with decreased nick butt and decreased Schirmer's. So all parameters are decreased. Next slide. Osmolarity was also increased for this patient. Next. You see here very irregular corneal surface, particularly on the right eye, with a lot of irregularity inferiorly. We also see a reddened lid margin on the upper lids. Next slide. So here on mammography, we see grade 3 dropout on the upper lids and around grade 2 on the lower. Can we play the video? Okay, so cannot play the video, but if you can see the video when you play it will show a tear breakup time of around 0 seconds and 2 seconds, right and left respectively. There's a lot of punctate diffuse epithelial erosions on both eyes as well. So our diagnosis or TFOD diagnosis for this was area break. Next slide. So our assessment was aqueous deficiency dry eye with meibomian gland dysfunction and toxic keratopathy secondary to brimonidine bilaterally. So our plan was to put punctal plugs on the patient, start her on preservative-free sodium hyaluronate every 2 hours, started her on anti-inflammatories like your loteprednol 3 times a day for 2 weeks, then cyclosporin shift twice a day. We also shifted her brimonidine to a preservative-free drop like your Taflotan S, and we then treated for MGD as well. Next slide. So thank you very much for your time and attention.
Thank you, Dr. Tan, for your very nice presentation. Now I invite our second speaker, Dr. Gary Kundu, with the topic of wavefront abrometry, taking your refractive game to a new level. Please, Dr. Kundu, the
Can I
floor
have
is yours.
the thing to move my slides? No, can I move my own slides? Thank you. So, post-lunch aberrations, yes, a little difficult. That itself is an aberration. So, aberrations, how much we should know, trying to basically simplify what we have spoken about, how we delineate aberrations. So I spoke about the fact that aberrations is important not only in your pre-operative planning. You need a good, yes, I know we are still at a stage where we need to invest in Corvus or which tomographer we should have. But to take it to the next level, aberrations and abrometry forms a crucial chunk on how we customize our surgeries. Many of you might have heard about topo-guided treatments, on the LASIK. Your unhappy patients post-operatively, aberrations form an important aspect of that. So that's very important when we are, trying to understand as to what aberrations are. So there are various abrometries. I don't want to go into that. I was speaking about how it compares with the gold standard, which is the eye trace. Varying principles, varying ways on which how we kind of image these patients. That is also something which is, important. But what is aberration finally? It is any optical system, right from cornea, you look at the lens and it goes through, is never aberration free. There would be some amount of aberrations. And it's important to understand that aberrations are like commensals. You need certain amount of aberrations for many functionalities. For example, if you need a certain depth of focus, you need spherical aberrations. Do we actually treat all of them? What is important, what is not? Therefore, understanding that is kind of very crucial because, for our optical system, many of the aberrations which we have can in fact be fruitful and help us in, doing many things we do simply because of the aberrations. So, there are varying principles. This is theoretical, don't want to go into it. Ray tracing is what the eye trace gives. What the Pentacam AXL wave does and gives us is the Hartmann check. So, different principles, measures the same. What it does is it kind of gives you the total eye aberrations, and then it kind of delineates and gives, and you look at the corneal aberrations, and then you look at internal aberrations. So it's not a mathematical formula. It's not like total aberrations is equal to corneal plus internal. I know it's difficult to explain. Internal aberrations, which is basically extracorneal, predominantly in our optical system is lenticular. That is an important aspect of what we need to remember. And therefore, understanding mapping not only corneal aberrations and total eye aberrations, even internal aberrations or lenticular aberrations is very important. So, Gatnell has also done work. How do we denote aberrations? So, to simplify it for all of you, you have certain amount of aberrations. Some are called lower order aberrations, some are called higher order aberrations. What we correct with the glass is lower order aberrations. Higher order aberrations cannot be corrected. You need certain other things to look at higher order aberrations. Zernike's polynomials, the pyramid which you might have seen, is a way of denoting it. 0, Z0, Z1, Z2. Lower, above that is higher. There is something known as primary spherical aberration. There is coma. There is trefoil. A lot of other things and a lot of interplay taking place. But just to keep it simple, you're looking at lower order, you're looking at higher order aberrations. What we need to know in our optical system and what all can affect aberrations is something which this talk will try to dwell into. What aspects of aberrations play an important role, and can tear film also play an important role? So, do we have a perfect tool? Difficult to say, but do we have a tool which is closer to perfection? Yes. Can hybrid tools help? Yes. So, there is always a give and take. Some of you might not really want to invest only in an aberrometer to start off with. It is always prudent to look at tomography and biomechanics. But what AXL wave is you're looking at also aberrations as a part of it. And I'll be speaking about how we compared the AXL wave, especially the aberrations aspect of it, with conventional devices towards the end. So the optical system should ideally be divided. Ideally, we look at cornea, which is being the first media into which we're decoding aberrations, but that is not the case. I spoke about in Pentacam OCT on the tear film and how we have kind of mapped it to look like something like a topographer because of the high resolution imaging we get on the Pentacam. So tear optics is very, very important. Now there's a difference between dry eye and tear optics. Dry eye can affect tear film, it does of course. That will cause altered scatter and alteration in the tear optics. But there are scenarios where patients who have mild dry eye in terms of the objective metrics, which was discussed earlier, but they still have altered tear optics. And that is something which can alter the way we image objects, image tools, and also that can also, alter the repeatability of instruments. So what is tear optics? This is something known as an optical quality analysis system, where, based on the scatter which we see at the level of the tear film itself, this is after, much before we even reach the cornea, it can kind of quantify the amount of scatter correlating with the amount of noise, and therefore that is telling me about the aberrations at the tear film interface itself. Now this is what we are hoping to kind of use the Pentacam OCT for, where if we are able to image the tear film level itself, we can use that to look at the tear film quality and also look at the aberrations as a consequence because of the tear film. So that is, the previous talk is something which is building onto this. So there are devices which are solely looking at tear optics, but can we, use hybrid tools or tools in combination? And I think Pentacam OCT could answer some of that. Epithelium, a lot of talk today on epithelium. You spoke about tomographers, sometimes epithelial changes, masking changes, which we see. Dr. Christina spoke about, dry eye, ocular surface issues. Epithelium is a surrogate marker for an undergoing inflammation, subclinical inflammation, no doubt. But epithelial remodeling and subtle changes in the epithelium can hold clue as to the ocular surface health. And understanding epithelium can also help us in understanding, your planning for surgeries, your post-operative outcomes. So I spoke about, we've published this many, many years back on something known as epithelial zernicase, where cornea, of course, we tend to look at it in terms of total aberrations, the anterior corneal aberrations and the posterior corneal aberrations. But the epithelium and the aberrations from the epithelium itself can hold clue as to how we detect diseases such as keratoconus a little early, and can hold clue in terms of post-operative unexpected outcomes post-surgery. So, epithelium profiling, which the pentacam OCT gives, you also have the total eye aberrations, which the pentacam OCT gives. OCRST is another device where we are able to quantify lenticular aberrations. So I spoke about the fact that you have aberrations coming from the tear film, you have aberrations coming from epithelium. You also, of course, have tools which are hybrid tools which can, image even the corneal aberrations. But lenticular, it's something which I said, internal aberrations are predominantly lenticular. But if you actually want to quantify whether, how the lens is behaving, this is an important tool, which is the OCRST. You don't need to have it. I'm saying your basic understanding or a basic a map reading of a tomography with an epithelial map should be more than enough. So what we showed is aberrations coming out of the epithelium is in fact very sensitive. Subtle changes is very sensitive in cases of an early ectasia, where epithelial remodeling around the area which is thinning shows up earlier as changes in the aberrations coming out from the epithelium, if that was simple to understand. And that could be a more sensitive indicator even before we go much deeper ahead in the eye. So that's how it is. I just spoke about the tear film and the epithelium, and a lot of studies we have done, imaged on tear optics, and epithelial zernicase play an important role. I haven't even reached the cornea yet. So this is a patient, this is the refraction, this is the epithelial thickness. You see the zernicase. This patient underwent surgery, and you see the outcome post-operatively. So what am I trying to say is, not only that you need to understand about aberrations, doing an epithelial mapping before surgery is very important, or at least a basic dry eye evaluation, because treating an already inflamed eye, which is what dry eye is, due to whatever causes it is, and doing a laser surgery on that could lead to sometimes suboptimal outcomes, not in all cases. And therefore, understanding that we need to treat these patients before we actually proceed with that is something which is quite important. So ideally, we should be measuring something a little deeper. I said about tools where you are actually imaging with epithelium. It's under the presumption that the epithelium is regular, but that is not the case in all scenarios. So an ideal device should actually be looking at epithelium, subtracting that, looking at a deeper level, which is the stroma. And the tools which are a combined tomographer with an epithelial map, such as a pentacam OCT, could kind of answer many of these questions. Or many of you just have a tomographer, you could use an epithelium from another ASOCT. But having said that, resolution is of course a challenge. And therefore, using an instrument which has a good resolution, a higher resolution OCT, is something which is always better and good to have. So I spoke about that. Now this is about the next layer. I haven't reached spoken about the full. I'm just going sequentially. I spoke about tear optics and how aberrations at tear optics. Studying that could help us in understanding how images or how repeatability of instruments work. Epithelium, your preoperative imaging is important. Also, your postoperative outcomes. Epithelial remodeling and epithelial zernicase is an important concept. Bowman's and Bowman's layer, I spoke about the Bowman's wrinkle and micro distortions, which I showed. In fact, ultra high resolution OCT helps us in imaging even very, very subtle early micro distortions, because many of these patients come back after surgery, an uneventful surgery, but you see patients presenting with that glare, with that halos. What could impact? This is one of the causes, and therefore, this is basically an aberration or an optical phenomena taking place at the level of the Bowman's because of those micro distortions. So utilizing using data, using tools such as the pentacam OCT would help in those scenarios. So I spoke about aberrations in cornea. You are of course, looking at cases where patients does not have that much amount of higher order aberrations, you need to decide as to what kind of surgery they're doing. Like I said, lower order aberrations are something which is corrected with your glasses. But what about higher order aberrations? When do we go for topo-guided treatments? That is where aberrometry and aberrations play an important role. I kind of touched upon this when I spoke about the initial presentation on pentacam axial wave in refractive surgery. You will have to look at how how you match the patient's acceptance with what you infer from the the pentacam wave in terms of the astigmatism. Look at whether there's any discrepancy between the patient acceptance and what is actually measured, and why is that happening. Majority of the time that happens is because of corneal aberrations, either corneal aberrations or lenticular aberrations. Customizing your refractive surgery based on aberrations is in fact a very, very important tool. I suppose many of the centers do use FORCIDs, other tools as well, and how you categorize these patients. What do you need to do? A topo-guided treatment or a wavefront-guided treatment? That is something which is important to understand. So this is just to understand that only lower order aberrations, yes, with glasses. Higher order aberrations, you do need treatment modalities which kind of dwell in that. That's beyond the scope of today's talk. So yeah, you can decide on what treatment you want. A wavefront optimized, a topo-guided treatment. How do you decide on that? And that is where aberrations preoperatively play an important role. I spoke about how aberrations have a role both pre and post. So that's how, using aberrometry, you can optimize your outcomes post-operatively. Lens, a lot of our optical system is, driven by changes in the lens. And it's not about cataract, it's about even patients who are much younger. You have a clear lens, but the concept of lenticular aberrations is something which people need to understand. The second aspect is, you get these patients who are in the, pre-presbyopic or presbyopic age group. You want to know what exactly is the culprit. Is it an early change in the lens? Or is it a problem in the cornea, and what would you treat? So this is a patient who comes for presbyopic classic. This is the refraction. You see a near-ad. Normal, we did a dry evaluation. Everything else was fine. We kind of did two things. One is, of course, look at a concept known as dysfunctional lens index. This is something which you get on the eye trace. We also correlated this with the pentacam nuclear staging. This is something which you get on the pentacam, which is basically telling me about subtle changes in the lens, which happens much earlier than it is clinically visible. Okay, so there are 3 stages of the dysfunctional lens syndrome. It's only in stage 3 later on when you can actually clinically see that there is a lenticular change. But it is objectively quantifying aberrations at the level of the lens so as to help us and understand as to where exactly the culprit is. You have a patient who's at an age group, 37 to 40, where he might have an early cataract, which is not discernible through a slit lamp evaluation. Are you going to really do a corneal refractive procedure, or whether a simple lens exchange would help? That is where the concept of lenticular aberrations preoperatively help. So you have eye trace, yes, but we've also compared the PNS, the pentacam nuclear staging, correlates very well, and these two are objective parameters for looking at lenticular aberrations. So this is a publication by our group on, in the Indian Journal of Ophthalmology, on how we kind of, I can maybe share it later, on how we build a nomogram around it, basically. So a little bit about advanced optics. This is a patient who's coming to us post-op. He's 6 by 4.5. A huge chunk of patients which come to us who are 6'6", but they're still not happy. They're the ones who keep cribbing. I'm seeing in fact, better than the last line, 6 by 4.5, but I'm somehow not happy. I'm still having glare. I'm still having halos. What do I do? And that is in fact increasing now. A lot of patients coming in with this grouping where they're fine, the vision is fine, but they have that. So that's where understanding aberrations play an important role. If you see, the ablation is kind of well-centered. Sometimes decentered ablations can lead to post-operative glare and halos. But if the cornea is normal, what is the problem? It is extracorneal, so therefore you need to understand what are the total ocular aberrations, and you need to understand what is the component of lenticular aberrations, which is internal, which is playing a role. So in this patient, it was predominantly aberrations due to extracorneal factors, which is predominantly lenticular, and invariably accommodative related trouble. It's a concept of non-strabismic binocular vision anomalies. Okay, accommodative excess, convergence insufficiency. These are other things which can get triggered after your refractive surgery. So how do we localize it to them? You of course can't do a pentacam look at ablation, but what next? That is where aberrations help us in kind of segregating, making our lives easier as to what could be a possible cause. And in this patient, it was an accommodative excess. And we did something known as orthoptics. We kind of did exercises. This is also something which is published, and this patient, in fact, did improve. So this is another of our preferred practice pattern publication where we looked at using aberrations for binocular vision assessment in patients as a routine. So what would be good is preoperatively just do at least do a basic screening NPA, NPC, in addition to your regular workup for your refractive surgery. And if they come back with some symptoms like glare and halos, remember an important aspect of non-strabismic binocular vision anomalies do form a chunk of these patients. Again, this is just to kind of objectively show you that this patient had an accommodative excess. Customization is the key. I spoke about the fact that all aberrations are not harmful. There are aberrations which are required. Do we require those aberrations? This is just taking it a little forward. When we do topo-guided treatments, so I don't know what happens here, but we do, in our center at least, it's moving towards cross-linkings with topo-guided customized ablation, where we are not correcting the PA, we are basically correcting the higher order aberrations so as to regularize the cornea so that post-operative acceptance of either glasses or contact lens improves. Okay, so this is what Dr. Brendan was also speaking about that. But when we are correcting those aberrations, are all aberrations to be knocked off? So this is where the concept of visual adaptive optics comes into play, where we've used devices such as this, where we can actually simulate which aberrations, if we knock off, would it be detrimental to their overall quality of vision or not? Okay, so there are certain platforms, treatment platforms, I won't be going into that, which allows us to kind of look at that, where we can selectively treat certain aberrations and selectively not treat. Not all of the platforms currently have that, but that is another future where customization and even the aberrations we're treating, plays an important role. So, to summarize, understand your optics, understand where exactly the problem lies. Understanding corneal aberrations, total aberrations plays an important role. Don't forget the role of epithelium, and of course, don't forget the role of tear optics and ocular surface and dry eye. So all of this in totality, from the tear film to the lens and beyond, is something which we need to understand to truly give customization to our patients. So yeah, thank you.
Thank you, Dr. Kundu, for your enlightening presentation. For the third speaker, I invite Dr. Christina Tan again to present the topic premium cataract surgery and the role of optical aberration.
So hi again. Dr. Gyrick already spoke about higher order aberrations, wavefront aberrometry. So we will be focusing more on Pentacam AXL wave for this topic, and this will also include higher order aberrations. Okay, so this lecture will be focusing on pre-op screening and post-op concerns for premium cataract surgery patients. Okay. So, screening for premium cataract surgery is crucial to ensure optimal patient outcomes, as we have described earlier. And we mentioned cataract surgery nowadays is, again, a refractive specialty with high patient expectations. So, we need accurate measurements to optimize results. Accuracy is needed for the measurements of keratometry values, axis placement, axial length, angle kappa, angle alpha, and higher order aberrations. So screening will also help to identify potential candidates that can benefit from these advanced lens platforms. So while ruling out those who may not be suitable, so the question is, do we place multifocal plus minus toric IOLs in all patients? Or are there some patients who are not suitable for these lenses? So we will be discussing this. So as we know, biometry measurements in the eye, particularly during cataract surgery planning, can lead to inaccurate intraocular lens measurements. And this can potentially result in undesired refractive outcomes. So common sources of error would include your axial length, corneal power measurements, and IOL positioning. So as we know, a difference of 0.3 millimeters in axial length measurement can lead to a refractive error of approximately 1 diopter. A 0.1 millimeter error in the measurement of the radius of curvature on the cornea can lead to a refractive error of approximately 0.5 diopters. And a 10-degree difference in toric IOL positioning can lead to 30-degree reduction in the lens's ability to correct astigmatism. So these are the tools that we can use for pre-op cataract screening. And of course, I already discussed dry eye evaluation as well. So these are included, which is the Keratograph K5M. For premium IOL selection, you can use the following displays, such as the Pentacam AXL Wave. So including your fast screening report, the full sequence overview, cataract pre-op display, PNS staging and 3D cataract analysis, wavefront aberrometry, and visual performance. Okay, so here are the list of features that I briefly mentioned. So these are functions that are important in preoperative cataract screening. So your Pentacam AXL Wave is a Scheimpflug-based tomographer. You can screen for ectasia, Fuchs, glaucoma with this device. You can have optical biometry, wavefront aberrometry. You can look at total cornea, anterior and posterior, internal, total eye, aberrations, as well as visual performance. It also has objective refraction as well as retroillumination to assess for cataract and toric IOL position. Sorry about that. Okay, so the first display that we would look at would be the fast screening report, which gives you a quick overview of the anterior eye segment, so where it can detect the abnormalities. So from this display, you can easily see if the patient has pathologies other than a cataractous lens. So here, the top row is used for glaucoma screening, and this evaluates anterior chamber angle, AC depth, and chamber volume. Next, we look at the display for corneal parameters. So this can be used to detect Fuchs endothelial dystrophy. And the next one would be for corneal ectasia and lens grading. So here we have the full sequence overview display. So this gives you a summary of the parameters for pre-cataract screening, as we can see here. So we can use the full sequence display to help us in premium IOL selection. So some patients are unhappy when you implant them with multifocal IOLs, probably from high irregular astigmatism and other higher order aberrations. So these steps can help us to identify these groups of patients and avoid us in implanting these premium IOLs in these patients. So these are 4 steps to help us improve good patient selection, and these can be seen in the full sequence overview or cataract pre-op screening displays. So these are the following steps. Step 1 would be to evaluate for irregular corneal astigmatism. Step 2 is detection of abnormal corneal shape. Step 3 is the evaluation of corneal spherical aberration, and step 4 would be the evaluation of corneal cylinder. So as we see here, step 1 will focus on irregular corneal astigmatism and higher order aberrations. So if the eye has pathology like patients with pterygium or mild corneal scars, it causes an irregular astigmatism, and these patients will have higher order aberrations. So if you implant a multifocal eye in these eyes, it will increase aberrations further. So these patients will tend to be more unhappy post-op. So the current cutoff for us would be 0.3 microns, and we should avoid placing a multifocal IOL if the value is higher than this. So you can also see here cord mu value The pentacam cannot directly measure angle kappa, but it can give you chord mu. So chord mu is the distance between the pupil center and the corneal vertex. And this is similar to angle kappa, which is the distance between your pupil center and the visual axis. So this is important in determining the position of the capsule in relation to the pupil center. So this is very important in lens centration. So if the angle kappa or chord mu is greater than 0.4 millimeters, the centration of the multifocal IOL would be a problem, and this should be avoided in these cases. So second step, we look at the corneal maps. So you can see here axial sagittal curvature maps as well as your total corneal refractive power maps. So we look at the corneal shape. You check for the regular topography and the regular astigmatism patterns. If the morphology is regular, then the patients will be good candidates for a toric IOL implantation. If it's very irregular, then you shouldn't put a toric IOL because it won't really help to correct your irregular astigmatism. So you can also use the maps to see if patients have undergone laser refractive procedures. So if patients have undergone myopic LASIK, hyperopic LASIK, or PRK, you will be able to see these in the maps. Sometimes patients won't be able to disclose this to you, so you can check it with these maps. So the next step is looking at corneal spherical aberrations, as this will affect the choice between aspheric versus spherical IOLs. So as we know, the average corneal spherical aberration is around plus 0.27 to plus 0.3 microns. So there is a naturally low positive spherical aberration in most eyes already. So when we put in a spherical IOL, it will increase the overall aberration of the eye. So too much positive spherical aberration can cause loss of quality of vision. It will also degrade your retinal image as well as reduce your contrast sensitivity. So aspheric IOLs, on the other hand, will not increase the overall spherical aberration of the eye. And many aspheric IOLs are designed actually to decrease the spherical aberrations. So because some of them have a negative spherical aberration effect. So by knowing the patient's pre-op spherical aberration and planning on which IOL to implant, you can predict the final total spherical aberration of the eye. And the goal would be to aim for a slightly positive spherical aberration, as this contributes to providing an improved depth of field, which is greatly appreciated by presbyopic patients. So you usually leave around plus 0.1 to plus 0.15 positive spherical aberrations for good results. So finally, the fourth step that we have would be to compare corneal astigmatism values, the SIM-K versus your total corneal refractive power. So the SIM-K, as we know, includes anterior corneal astigmatism only, while your total corneal refractive power would include anterior and posterior corneal astigmatism. And this also takes into account refractive index and corneal thickness measurements. So if the magnitude and the axis of both the SIM-K and the TCRP is the same, then the patient will benefit from a toric IOL in these cases. So here's an important, Okay, so this is a very important slide that you can use for 4 steps to success. So this takes into account, again, irregular astigmatism, regular corneal shape, corneal spherical aberration, and comparison of SIM-K and TCRP values. You can also see here in the red box additional corneal parameters such as your back-front ratio or B/F ratio. So your B/F ratio will help you to detect untreated versus treated corneas. So you'll be able to know if patients have undergone either a myopic LASIK versus a hyperopic LASIK. So another useful display would be, as Dr. Garrick mentioned in his talk, the nucleus staging or PNS and 3D cataract classification display. So we can use this for cataract classification and determining lens opacities in 3D. So next display is the wavefront display, which shows total eye aberrations using the Hartmann-Shack wavefront sensor. So here you have the summary of the parameters where you can see pupil diameter, refraction, higher order, lower order, spherical, and coma aberrations. The Zernike polynomials are displayed from first to sixth order and can be displayed in either bar view. You can see them also as a pyramid view or a vector view. So this slide is quite important in terms of your lower order and higher order aberrations. So the Zernike polynomials are ranged from lower order to higher order aberrations, and there are a lot of things to look at here in this slide, but you need to focus on lower order aberrations that can be corrected with prescription lenses. Usually these are like Z1 to Z2. The higher order aberrations, the most important of which would be your Z4 and Z3. So you have the vertical trefoil, vertical coma, horizontal trefoil, as well as your spherical aberrations, which is Z4. So these are the ones that are very important, which causes the most visually significant aberrations, such as your glare, halos, and starburst patterns. So the next display is the visual performance display, which simulates the patient's quality of vision as seen here in the letter E. So here you can see a visual simulation of aberrations in the cornea, internal and total eye aberrations. So you can see in this example that the visual disturbance is seen internally, and this usually suggests a cataractus lens in a preoperative patient. Next, you can do retroillumination in phakic and pseudophakic eyes. Retroillumination will help you to assess for cataractus lens changes. In postoperative patients, you can visualize the presence of posterior capsular opacity. Another thing that you can see in retroillumination would be patients who have had pseudophakic multifocal lenses and toric lenses as well. So you can visualize toric IOL alignment as well as lens placement in these cases. So after doing the pre-op screening, next thing to do would be to calculate the IOL power. So the IOL Pentacam Wave utilizes an IOL database where constants are embedded, and you can input your most used IOLs with up to 50 IOLs available in the database. So each specific template has templates for monofocal, toric, and post-refractive cases. And each surgeon can define your own target refraction and surgically induced astigmatism as well. So this is what the IOL calculator looks like. It's very convenient with multiple tabs, and you can select up to 4 formulas being displayed simultaneously. So again, we know for IOL calculation, these are the suggested IOL formulas to use in different situations. So for non-treated corneas, you can use the patient's eggshell length in accordance. So formulas like your SRKT, Hoffer Q, Haigis, Holiday 1, are used in accordance to your eggshell length measurements. For treated corneas, patients who have undergone myopic LASIK procedures can use the Potvin-Shamas-Hill formula. For those with radial keratectomy, they can do Potvin-Hill formula. And those with known pre-op K values, you can do the double K formulas. So Barrett also has a range of formulas for different situations. So you can use the universal 2 formula for normal eyes, the Barrett toric for toric IOL calculations, and the Barrett True K for treated eyes. So these are already available in the Pentacam AXL Wave IOL calculator as well. So sorry about that. So here you can see the Barrett calculators as seen in the tabs here, Barrett Universal 2, Barrett Toric, and then also your Barrett True K. For the Barrett True K, you can choose the option which kind of procedure the patient had. You can choose if the patient underwent myopic LASIK, hyperopic LASIK, etc. Another new formula that is included in the Pentacam would be your Olsen formula. So this Olsen formula utilizes ray tracing approach, and it considers the specific optics of the IOL and the eye's unique dimensions. So this will differ significantly from older formulas because it focuses on the physical position of the IOL within the eye, rather than just computing for refractive power. So this is achieved through a C constant, which relates to the IOL's position in the anterior chamber. So it also uses the thick lens approach, and unlike simpler formulas that treat lenses as thin, the Olsen formula accounts for actual thickness and shape of the IOL and other ocular components. So this formula is suitable for any IOL configuration, be it your spherical, aspherical lenses, toric, multifocal, or a combination of which. It's also suitable for any corneal shape such as keratoconus, post-LASIK, PRK, RK, and other corneal transplant procedures. So it does not need pre-op K values to work, but it's beneficial to manually include if such parameters are accurate. Okay, so this is how it looks like on the Pentacam AXL wave display. So here we see the Olsen ray tracing formula, and a new addition to this formula is the calculation of toric IOLs in post-corneal refractive surgery patients. So as of the moment, only the Olsen ray tracing formula has this capability. So again, we see here suggested IOL formulas for different types of eyes. So it's based on individual patient circumstances. So for corneal transplants, you can use the Olsen ray tracing. For refractive surprises, you can use formulas like your Barrett RX. This is an algorithm that you can use to be able to know which formulas you can use for different subsets of patients. So it's similar to the table that we have shown earlier. So we already discussed pre-op screening and IOL formula selection, but what about patients with less than desirable results post-op? So the last topic would be focused on managing post-op concerns in the case of refractive surprises. So you have your Barrett RX to be able to resolve these issues. So refractive surprises are rare, but on occasion you can still get these cases where patients are unhappy with their vision. So Barrett RX formula can be used in these instances, and steps for evaluation would include to perform objective and subjective refraction. You have to check the IOL position, and you use the Pentacam AXL wave for functions like this, as well as Scheimpflug tomography. So here we have retroillumination to check IOL alignment if the IOL is on the correct axis. You can also see tilting present if it is present. So the Barrett RX will offer 3 solutions for the refractive surprise. So either an IOL exchange, insertion of a piggyback IOL, or to rotate the toric IOL to its correct axis. So there are 2 calculation methods that are used. The first one is the ELP, or effective lens exchange, which is the assumed error in predicted IOL position, which is the default calculation usually used. And another calculation would be the IOL, which can be used for post-LASIK, RK, and low-power IOLs. So this is what the Barrett RX calculator looks like. So if you have a patient with where the alignment of the toric IOL is not correct, you can do toric IOL rotation. So this is the calculator that we will use for it. Here in this display, you can see pseudophakic refraction data is input above, and then you select the ELP calculation method and rotate toric IOL options. So the Pentacam AXL wave will then calculate the recommended IOL axis and predicted post-op astigmatism. The next one would be the piggyback IOL. So for piggyback IOLs, post-op refraction is input above and the piggyback IOL option is selected. So Pentacam AXL wave will calculate and give you additional power needed to correct the refractive surprise. Lastly, we have the IOL exchange option. So pseudophakic post-op refraction is input again above. Pre-op values are also available, and exchange IOL option is selected, and the Pentacam AXL wave will calculate and give you the appropriate IOL power to do the exchange. So we have now tackled pre-op screening, IOL calculation, and post-op refractive surprises. This is my last slide. Thank you so much for your time and attention.
Thank you, Dr. Tan. Now, I invite the fourth speaker would be Dr. Ruchita Ranti. Please, Dr. Ruchita.
Oke, Assalamualaikum warahmatullahi wabarakatuh. Saya Dr. Recita Ranti dari National Eye Center Surabaya yang pada siang ini akan membawakan kasus. Sebenarnya untuk kasus ini tidak terlalu kompleks ya, cuman kita di sini menekankan bagaimana dengan mudahnya kita bisa mengevaluasi pasien-pasien katarak kita menggunakan pentakem AXL untuk men-screening sehingga dapat menghasilkan outcome yang baik. Tadi untuk teori dan lain-lain sudah sangat baik dijelaskan oleh speaker sebelumnya. Oke, jadi memang seperti yang sudah kita tahu bahwa demand dari bebas kacamata pada pasien-pasien katarak itu semakin hari semakin meningkat karena kebutuhan dan juga aktivitas yang sudah berubah. Jadi untuk memastikan pasien-pasien katarak kita mendapatkan hasil yang optimal, kita juga harus melakukan screening diagnostik yang juga optimal untuk mendapatkan hasil yang baik. Jadi pentakem sendiri itu merupakan sampel tomografi yang juga bermanfaat. Salah satunya adalah selain untuk corneal topografi dan tomografi, fungsinya adalah sebagai biometri. Pada pentakem AXL di sini kita bisa menghitung bagaimana panjang aksial length, ACD dan juga WTW dan lain-lain. Kemudian di situ ada fungsi juga wavefront abrometri, jadi bisa memeriksa juga bagaimana corneal abrometri. Kemudian di sini yang penting dalam pemasangan multifocal IOL adalah adanya angka code mu yang bermanfaat untuk memilih kandidat dari pasien. Code mu itu sendiri merupakan jarak antara visual axis yang kalau kita tarik garis antara visual axis dengan garis di pupil center, maka akan menghasilkan angka yang disebut dengan code mu. Semakin besar pupil maka angka code mu-nya juga semakin meningkat. Untuk yang value yang tinggi lebih dari 0,42 maka dapat meningkatkan resiko pasca operasi adanya keluhan seperti visual disturbance, glare, halo, kemudian berkurangnya sensitivitas kontras, terutama ada pasien-pasien yang dipasang multifocal IOL. Jadi ini pasien profil perempuan usia 47 tahun dengan penurunan tajam penglihatan dan ingin untuk bebas kacamata. Dari pemeriksaan medical dan ocular history tidak ada kelainan yang lain dengan penglihatan awal 3/60 dengan koreksi bisa mencapai 0,2, mata kiri 2/60 dengan koreksi bisa 0,5. Di sini kita lihat dari pemeriksaan katarak pre-op ya, sebenarnya kita sudah mengetahui lebih dari 90% bagaimana kondisi dari pasien ini. Jadi yang pertama seperti yang dibilang dengan speaker sebelumnya bahwa di sini ada 4 angka. Yang pertama adalah kita melihat regular astigmatisme dari pemeriksaan kurvatura kita bisa melihat bagaimana kondisi kornea topografi. Ini juga bermanfaat misalnya pasien kita bukan virgin eyes, misalnya sudah dilakukan lasik, miopic lasik, hyperopic lasik. Kita bisa melihat secara singkat bagaimana kondisi kornea di situ ya, apakah ada desenterasi dan lain-lain. Kemudian yang kita lihat adalah bagaimana astigmatnya. Jadi di sini kita bisa melihat adanya SIMK itu dari permukaan anterior kornea kita bandingkan dengan total kornea refractive power. Jadi kita bandingkan apabila tidak terlalu jauh jaraknya maka itu kandidat yang bagus untuk pemasangan toric IOL. Kemudian yang kedua adalah kita melihat adanya sini code mu ya. Code mu pada pasien ini terdapat peningkatan code mu yang agak tinggi yaitu 0,45 dengan corneal HOA pada 4 mm 0,142. Jadi ini masih tergolong normal. Kemudian dari spherical aberration-nya dari 6 mm didapatkan 0,256 atau masih di bawah 0,4. Jadi ini juga masih tergolong normal. Kemudian kita lihat di sini juga ada weight to weight. Ini juga nanti bisa bermanfaat terhadap pemilihan IOL, misalnya phakic IOL. Kemudian ada kita juga bisa melihat bagaimana pakimetrinya untuk pasien-pasien kandidat untuk lasik. Kemudian di sini juga ada pupil diameter. Pupil diameter ini juga bermanfaat pada pasien-pasien multifocal IOL di mana semakin besar pupil kita tahu bisa meningkatkan spherical aberration-nya dan mengganggu kualitas penglihatan pasca operasi. Sini juga ada anterior chamber angle. yang mana juga nanti bisa kita melihat apakah ada kondisi-kondisi sudut sempit. Kemudian juga ada anterior chamber depth eksternal dan internal. Kemudian ada PNS. PNS itu pentacam nuclear score, di mana grading mulai 1 sampai 5. Jadi di sini kita bisa melihat bagaimana ketebalan katarak. Bahkan mungkin kalau masih PNS 1 biasanya secara AFU kalau kita lihat langsung mungkin tampak baik-baik saja. Kemudian kalau kita lihat dari pemeriksaan pentacam ini bisa keluar angkanya 1 karena memang berarti sudah mulai ada kekeruhan dari lensa. Kemudian juga di sini ada pemeriksaan di bawah sendiri ya, ada hasil dari axial length dan juga SNR. SNR itu adalah kita melihat kualitas dari jepretan pentacam yang kita dapatkan. Oke, jadi seperti yang sudah dijelaskan sebelumnya, ini adalah interface dari biometri pasien tersebut ya. Jadi di sini semua data sudah masuk, di mana kita juga bisa memasukkan refraksi di bagian atas. Kemudian yang menarik adalah di sini untuk axial length itu bisa kita kombinasikan seperti yang kita tahu bahwa pasien-pasien kita itu jarang ya yang mungkin baru grade 1, grade 2 gitu, sehingga pada katarak yang tebal misalnya sehingga biometri optical ini nggak bisa menembus, pada kolom di atas itu di Excel optical kita bisa klik di situ. Bila tidak bisa tembus dengan biometri optical pada katarak yang tebal, kita bisa memasukkan hasil biometri imersi bahkan biometri aplanasi dari pasien tersebut. Jadi kita masih bisa menggunakan berbagai data dari pentacam, hanya axial length saja misalnya tidak bisa ditembus, kita ambil dari modalitas yang lain. Kemudian di sini juga ada SIA. Jadi SIA ini penting kalau kita mau memasang torik IOL misalnya, di mana kita bisa memasukkan SIA dari masing-masing surgeon yang ada di tempat tersebut. Jadi tidak perlu kita masukkan secara manual lagi. Seperti tadi sudah disebutkan bisa kurang lebih sampai 10 surgeon. Lalu di sini ada code mu yang agak meningkat. Jadi kalau memang di atas 0,42 itu akan ada muncul warning sign-nya kuning sehingga tidak terlewat ya oleh dokternya. Kemudian saya rasa sudah, itu sama dengan yang tadi HOA dan lain-lain. Dari pemeriksaan biometri ini banyak lensa yang bisa kita masukkan juga. Jadi untuk surgeon preference-nya misalnya pada lensa-lensa yang tidak butuh torik ya, speris aja. Kemudian tab berikutnya ada lensa torik atau post refraktif atau pada torik post refraktif, sehingga kita bisa menghitung atau menilai dan bahkan membandingkan antar IOL itu dengan lebih cepat dan optimal. Juga bisa membandingkan antar formula. Misalnya pada kotak yang sebelah kiri itu kita mau pasang lensa dari Alcon dengan SRKT, sebelahnya lensa yang sama tapi dengan baret. Gimana sih hasilnya, sama apa enggak gitu. Kita bisa mengcompare dengan cepat. Begitu pula misalnya kita mau dengan formula yang sama kita pakai lensa yang berbeda, bagaimana hasilnya, seperti itu. Oke. Ya, ini tadi seperti yang sudah dijelaskan, pemeriksaan aberometri itu juga penting pada pasien-pasien yang akan dipasang multifokal IOL. Jadi tadi sudah dijelaskan kalau untuk higher order aberration yang penting adalah 1 spherical aberration, kedua adanya koma ataupun trefoil. Jadi ini juga bermanfaat pada, ini kebetulan pasiennya adalah virgin eye. Jadi kalau dia masih dalam masuk populasi normal maka hasilnya mungkin masih dalam rentang normal, tapi akan berbeda hasilnya kalau misalnya pasien misalnya poslasik, hyperopik lasik, myopik lasik akan menimbulkan nilai dari abrasion yang pasti berbeda. Kemudian kita juga dari sini bisa tahu misalnya ada pasca lasik dengan desenterasi, biasanya nilai komanya akan meningkat. Nah itu apa yang harus kita lakukan? Apakah langsung dioperasi katarak atau kita betulkan dulu desenterasinya? Karena keduanya sama-sama bisa mempengaruhi tajam penglihatan atau kualitas penglihatan pasca operasi. Kalau pada pasien ini dapat kita lihat abrasi dari 6 mm didapatkan HOA-nya yang agak meningkat 0,370, tapi ini 6 mm. Kemudian untuk spherical aberration-nya 0,256 masih dalam batas normal. Kemudian selain bentuk piramid, ada bentuk yang lain dengan menggunakan tabel seperti ini, kita juga bisa melihat apakah lebih detail bagaimana dari masing-masing higher order abrasion. Oke, jadi dari pasien tersebut dapat kita lihat untuk topografinya dalam batas normal, kemudian terdapat regular astigmatism yang tidak terlalu tinggi, kemudian dari HOA-nya masih dalam batas normal 0,142, spherical aberration normal 0,256, masih di bawah 0,3, kemudian dari kalau HOA yang 6 mm 0,370 dengan cord mu yang sedikit meningkat dari 0,42 yaitu 0,45, pupil diameter yang relatif kecil yaitu 3,94 mm. Dengan pasien ini sangat ingin sekali untuk bebas kacamata, sudah dijelaskan mungkin akan ada resiko ketidaknyamanan dikarenakan cord mu-nya yang sedikit meningkat gitu ya, tetapi pasien tetap ingin bebas kacamata sehingga tetap dipasang multifocal IOL yang sudah dengan diskusi sebelumnya. Jadi untuk hari pertama untuk visus naturalisnya masih 0,6, 1 bulan bisa 0,8, kemudian tidak ada keluhan adanya glare, halo ataupun gangguan penglihatan malam. Pasien sangat puas dan bebas kacamata. Jadi pada kasus ini didapatkan hasil yang memuaskan, artinya tidak ada visual disturbance dari walaupun cord mu-nya agak meningkat. Kemudian kenapa bisa seperti ini? Satu, pasiennya memang regular astigma, tidak ada irregularitas di situ. Kemudian HOA-nya masih baik. Lalu pupil size-nya mendukung, dia nggak terlalu besar sehingga bisa mengurangi juga efek dari abrasi. Kemudian pada saat operasi kita juga harus pastikan bahwa posisi IOL itu well centered sehingga tidak menambah gangguan dari cord mu-nya yang lebar. Kemudian mungkin juga pasiennya punya good neural adaptation, ini nggak boleh kita lepaskan karena walaupun kadang pemeriksaannya itu bagus semua tetap nggak enak, ternyata dia memang neural adaptation-nya nggak bagus gitu. Kemudian psychological factor ini adalah satu, kita sudah menjelaskan kepada pasien konsep dari refractive surgery ya, kita under promising over delivery begitu ya. Jadi kita sudah setting ekspektasi pasien apa yang kira-kira bisa terjadi, kemungkinannya apa yang akan dirasakan sehingga pasien sudah lebih siap dan ekspektasinya tidak terlalu tinggi, ternyata hasilnya tetap bisa memuaskan. Jadi sebagai kesimpulan, pentacam ini menurut saya merupakan alat yang praktis ya untuk kita, apalagi pemula seperti saya untuk mulai menginjak untuk memasang IOL premium terutama multifocal IOL. Kemudian adanya HOA yang rendah ini juga sangat mendukung untuk pemasangan multifocal IOL. Kemudian jangan dilupakan aberometri dan juga topografi pada pasien selection terutama pada pasien-pasien post refractive surgery. Kemudian kita juga harus personalized planning, artinya tidak hanya kita melihat dari angka-angka itu tetapi kita juga lihat bagaimana pasien dan juga kondisi-kondisi lainnya yang mendukung. Oke, sekian dari saya, semoga membantu. Assalamualaikum warahmatullahi wabarakatuh.
Rucita untuk presentasinya yang sangat menarik. I invite our last speaker, Dr. Gairi Kundu.
So my work
Please,
is already
Dr.
easier
Kundu.
because I think it's already been covered. And trust me, if I'm there for another day, I'm already started to understand Indonesian. Maybe another day I should be able to converse with you. But having said that, my topic was on examples. I will. Can you go to the presentation one? It's already been covered wonderfully by my preceding speakers. I just want to deal with one map. And I'll sum it up, maybe a minute. I don't want to keep you guys from tea. It's either after lunch or before tea. Presentation one. Go down, go down. No, no, applications. Yeah. I'll do it. Just put it on one of them. Yeah, just go up. Yeah, here, here. So just to summarize, I'm not going to repeat things, but you need to choose your maps correctly when you're looking at using. So cataract surgery is also refractive surgery. Um, she spoke about the fact, Dr. Christina spoke about the fact that in an virgin eye, of course, the ratio of your posterior to anterior is constant, but that's not the case with, irregular corneas or your post-refractive eyes. And therefore, using what maps for what scenarios is something which is very important. I'm going to skip majority of it. So what I want to specifically dwell on is on EKR, okay, which is the equivalent K reading map, where the Gulfstrand's eye is ideally, the ratio of posterior to anterior is constant. It also gives an adjustment for the posterior separately, therefore is more feasible for post-refractive outcomes. Okay. Now, what is an equivalent K reading map? Is that it tells you the range of the dioptric distribution on the cornea. So more closely spaced it is, more regular the cornea is. In cases where it is widely distributed, there is a large difference or large distribution. So it's telling me about it being irregular, and whether these corneas are suitable for multifocal IOLs is of course a question. Okay, so specifically, the 4.5 millimeter zone is where you need to look at it. And in an ideal scenario, the CKR map on the pentacam, the mean 65, the global mean EKR, and the highest peak, there should be very little difference between that. That is something which you need to remember. Less than a 0.5 diopter difference, okay, which is telling me that it is a regular cornea. And if you see the peaking of the dioptric values in the 4.5 millimeter zone, something like a skyscraper, not a widely distributed zone, is also telling me about it being more regular than irregular. And these are candidates which could, help in that. So she's already spoken about chord mu and the role of chord mu. I will not go into that. So so the basic scenarios are, of course, your virgin eye cataracts. You can, of course, optimize it. Your post-refractive surgery. So a lot of the refractive surgeries done 20 years back, including post-RK irregular corneas, are coming back to us with cataracts. They're aging now, those patients. And therefore, understanding which formulas which is already dealt with on, which are the formulas which you need to use is something which is important. And also patients coming in with irregular cornea. So these are the three, case scenarios which we use. So it's important to have a checklist. You need to look at your maps, look at the correct maps. You need to look at aberrations. And she has sequentially spoken about how you, go about looking at aberrations, looking at the axial length. I'm going to skip at this for the, because it's already been done. You can customize what IOL power formulas you have. Surgeon specific, this is how I do it. I can actually alter the way, what is my lens preference, what is my IOL formula preference. That all can be, plugged in and put into this. So that is something which is interesting. And you can, of course, like I said, make a list of the preferred IOLs and IOL formula formulae. So that is also important. She's spoken about this. So yeah, always speak to the patients before planning up these cases, because post-operative majority of the times it still is a little unpredictable, but you're trying to reduce that unpredictability by optimizing and looking at these preoperative factors. At least in the country I come from, in India, not many people are in the habit of using preoperative, pentacam or looking at higher order aberrations before doing cataract surgery. That trend is changing now as to where you're looking at aberrations, you're looking at what maps on the pentacam to help you, do these premium IOLs. So this has already been dealt with. What I would want to end with is, you get scenarios like this, patient coming in with keratoconus, patient was on scleral lenses, does not improve because of cataract. And if you see the EKR, so what lens can you give? This is a food for thought in such scenarios. Of course, keratoconus, it would be some irregular corneas. The stepwise phenomena should still be the same, where you're looking at EKR, you're looking at higher order aberrations, which should anyway be high in such a scenario, and then planning up what surgery you could do in such cases. So customized surgeries, premium IOLs, when to use, when not to use, concept of dysfunction lens index, which I already spoke about, how it correlates with the pentacam nuclear staging. This is again data which we have shown about the correlation. And before I end, we have studied AXL wave repeatability, has good repeatability. Also compared the extra part, which is basically the aberrations, and how it compares to a gold standard. So any device which comes in, you have a lot of repeatability and agreement studies, how accurate readings when it's taken in quick succession, and whether it matches with the gold standard. And that is what we do for any device, whether it's any hybrid device, compare that with the Scheimpflug or of the Pentacam. And if Pentacam came with an abrometer, we compared that with iTrace, and we found good repeatability and very good agreement. So it can be used interchangeably with iTrace for the aberrations which I spoke about in customizing your refractive surgeries as well as your premium cataract surgeries. And this a series of publications which we actually came out with. In terms of how dry eye affects repeatability, this is a paper which was on correlating tear optics and how tear optics affects the repeatability in some scenarios. And we found that though it does affect, you still find the repeatability to be quite good and accurate. So be aware that dry eye can affect, tear optics can affect the repeatability. So therefore you know that you need preferably take multiple scans. Somebody had asked me, take an average of the scans, and that's what would be helpful. So yeah, hybrid imaging, next imaging, accurate imaging, I think that's what the future is. Thank you.
Thank you, Dr. Eric. Now, sekarang kita memasuki sesi diskusi untuk kami undang kembali untuk naik ke atas panggung para panelis, Dr. Ucok, Dr. Dini, dan Dr. Emi. Kami persilahkan. Untuk para peserta, jika ada pertanyaan, mohon bisa disampaikan langsung. Silakan, Dr. Sheni.
Thank you very much for all of the speakers. I think this question is for Dr. Christina. What is your considerations to choose for dry eye patients? I mean, between the simple sodium hyaluronate or diquafosol or cyclosporine, or we consider to use Pongtabla? Thank you.
Yes, thank you for the question. I usually treat patients based on the TFOD, tear film oriented diagnosis, by Professor Yokoi from Japan. So it's used as a treatment guideline in the 80s. So we're more towards the Asia dry eye classification than DUS. So how we do it is when we already determine the type of dry eye that the patient has, because you already know which lipid layer, which layer is affected, either the aqueous, the mucin layer, or the aqueous layer. So from there, when you know which layer is affected, then you can already streamline your diagnosis and management. So I think I already placed a slide there of the treatment options, the tear film oriented therapy. So usually it will suggest a mucin secretagogue, which is diquas. So diquafosol would be one of the most commonly used treatment options for the aqueous deficiency, lipid layer, even the mucin layer deficiency. In terms of inflammation, we look at the tear osmolarity as well as the OSDI. When you see patients that are very symptomatic, in what I mean to say is they have moderate to severe symptoms already, so they're very symptomatic in their day-to-day activities, as well as increased tear osmolarity, then you can include your anti-inflammatories as well. So it really depends on the duration. You can see the patients maybe after 2 weeks of treatment and see if there is improvement. And then after improvement, you can already taper your treatment options for them. You can use longer duration of immunomodulatories like your cyclosporin in patients with long-standing dry eye. So it's very, very important to use in patients with a lot of inflammation. If you see the case that I had, the third case that I showed, she had glaucoma with toxic keratopathy. They worked really well with cyclosporin treatment. So we usually give it for a very extended amount of time. For that patient, she improved on the 3rd month mark, and we kept on continuing the Icurvis or the cyclosporin. The cyclosporin that we use is usually 1%, actually 1%, which is Icurvis. Yes.
Okay, thank you, Dr. Tan. Apakah ada pertanyaan lagi dari audiens? Mungkin dari panelis ada komentar, dong?
Dr. Garnik, I want to ask you, can we use equivalent keratometry reading for all our cases?
Yes, you can. Even in cases where you're planning monofocal IOL as well, it would be a good practice to look at EKR and the keratometric distribution.
Yeah,
Not only for premium IOLs. That is something we do also. You know, it's a good habit to look at the cornea because you're finally, doing a surgery. Though it's cataract, it's finally a refractive surgery. But of course, having said that, in our decision making for premium IOLs or in cases where we need to put a multifocal IOL or not, EKR is something which is very helpful. And of course, there are other steps which Dr. Christina and my colleague has also spoken about in terms of how you sequentially look at what parameters, in addition to keratometry, you also have to look at aberrations, and that finally helps us arrive at that decision. Yes.
Which one better between simulated K and EKR?
I didn't get it. Equivalent K and EKR is the
simulated
same.
K.
Is the same.
The same.
Yeah, EKR
the same
and equivalent
result.
K reading is the same, yes.
Okay, thank you.
Terima kasih. Mungkin ada pertanyaan, silakan para audiens. Jika tidak, mungkin saya akan menanyakan kepada para panelis. Bidang saya refraksi dan visual optimasi. Saya beberapa kali itu mendapat rujukan pasien dari teman-teman SPM, pasien post-op refractive surgery dengan visus 6/6, tetapi tidak puas dengan hasilnya. Mereka mengharapkan saya mengoptimasi penglihatannya. Mungkin ada saran, Dok? Pasiennya diapakan?
Ini post LVC atau post katarak premium
Biasanya
surgery?
post premium katarak surgery.
Iya, mungkin ini ada kaitannya dengan yang udah disampaikan Dr. Gairik Kundo sama Dr. Krisnatan sama Dr. Cita tadi. Jadi poin-poin penting pre-op sebelum memasang katarak premium itu terutama kelihatannya sepele, spherical abrasi, dan ternyata spherical abrasi itu juga menentukan outcome. Kemudian lebar pupil ini juga kalau pupilnya terlalu lebar tentunya abrasinya juga tinggi. Nah itu pasti juga menimbulkan resiko unhappy patient. Jadi mungkin pesannya untuk teman-teman di sini yang akan memasang katarak premium surgery, tadi sudah dapat checklistnya dari Dr. Kristinatan, tadi ada slide-nya yang sangat baik. Jadi step-step itu jangan dilewatin supaya pasiennya happy. Karena kalau sudah unhappy memang agak susah. Mungkin post-op-nya Dr. Nike bisa cek lagi checklist examination pre-op itu, tapi untuk post-op-nya supaya kita bisa nemuin solusinya ya.
Solusinya itu, Dok, yang sering susah ya. Baik, kalau tidak ada pertanyaan lagi, mungkin untuk sesi ini bisa kita akhiri. Thank you for all the speaker for your very inspiring talk. Thank you. Terima kasih untuk semua audiens, panelis juga terima kasih sekali. Kita akhiri dulu sesi ini. Terima kasih atas perhatiannya. Semoga bermanfaat. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih luar biasa. Thank you to all of the speakers. Thank you for the presentation. Thank you so much untuk panelis Dr. Uco, Dr. Dini, Dr. Emi, dan juga Dr. Ria. Thank you so much. Bagaimana Bapak Ibu masih semangat? Ngantuknya sudah pergi? Sudah ya. Nah, jangan khawatir karena sesaat lagi kita akan bisa menikmati coffee break yang sudah disiapkan untuk bisa Anda nikmati. Tapi sebelumnya Bapak Ibu, saya mau mengingatkan bahwa gala dinner malam hari ini cukup bisa dibilang memanaskan gala dinner nanti malam ya, karena hadiahnya ini luar biasa, yaitu ada sunglasses dan yang paling luar biasa adalah hadiahnya paket perjalanan ke APAO 2026 Hong Kong. Ini sudah termasuk tiket, hotel, dan juga registrasi. Gimana? Ngantuknya langsung hilang ya dokter ya? Baik, dan saat sebelum kita menikmati coffee break yang disediakan, kita akan sama-sama mendengarkan industrial presentation dari PT Optik Tunggal Sempurna. Kepada PT Optik Tunggal Sempurna, waktu dan tempat saya persilahkan.
Oke. Selamat siang dokter sekalian. Waduh, luar biasa, tapi saya masih mendengar sekitar 2 sampai 3 orang dokter ya. Jadi kita mulai sekali lagi. Selamat siang dokter sekalian. Kurang dikit dok, kurang dikit. Mungkin sekali lagi biar tambah semangat. Selamat siang dokter sekalian. Oke. Sebelumnya mungkin kita sebelum masuk ke materi, mungkin karena dari tadi Dr. Nurdin sudah mengawali pantun, Pak Alam juga sudah menengahi pantun juga, mungkin saya terakhir di produk presentasi juga akan ngasih pantun mungkin ya. Jadi pantunnya seperti ini, pagi-pagi bersama Bapak pergi ke ladang. Bagus, ada cakepnya, semangat ini. Naik sepeda bersama Bapak sampai ke Argentina. Makasih ya, saya suka responnya seperti ini. Selamat siang dokter yang saya sayang, kita bergembira bersama PT Optik Tunggal Sempurna. Oke, sebelum masuk ke materi, mungkin biar tambah semangat lagi, saya meminta para dokter sekalian untuk berdiri terlebih dahulu. Kita fun terlebih dahulu. Kita berdiri, rentangan tangan, mungkin kita olahraga sebentar biar aliran darah dari kepala sampai ke lutut, lutut sampai kepala lagi bisa teraliri dengan baik. Silakan dok. Ya bener, stretching dulu. Stretching dulu, oke. Saya minta untuk dokter untuk berdiri, sudah berdiri semua? Oh sudah, sudah berdiri semua ya. Mungkin ini adalah beberapa lagu yang pernah didengar karena kita sering bersama, mungkin ada kolega ataupun anak kecil seperti itu bernyanyi lagu ini dan dansa dengan lagu ini, mungkin sedikit tahu untuk Bapak Ibu dokter untuk mengetahui lagu ini ya, siap ya. Jadi mungkin kita rentangkan tangan dulu biar gak kesenggol kanan kirinya, nanti ricuh seperti itu. Kita mulai ya dokter, jadi nanti kita akan ada mulai videonya terlebih dahulu. Oke, yang sudah tahu ya. Kita ikutin gambar yang ada di layar, oke? Atau ikutin saya juga nggak apa-apa, yuk. Lari di tempat. Lari di tempat yuk. Biar sehat semuanya, yuk. Wah, baby shark,
baby shark, baby shark, baby shark. Mommy shark, mommy shark, mommy shark,
sekarang baby.
mommy shark.
Daddy shark, daddy shark, daddy shark, daddy shark.
Grandma.
Grandma shark, grandma shark, grandma shark,
kelas lihat tangannya.
Grandpa Shark, do 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 do. Grandpa Shark, do 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 do. Grandpa Shark, do 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 do. Grandpa Shark.
Let's go hunt.
Let's go hunt, do 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 do. Let's go hunt, do 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 do. Let's go hunt, do 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 do. Let's go hunt. Run away,
Lari teman dok, lari teman.
run away, do 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 do. Run away, do 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 do. Run away.
Terus lagi.
Safe at last, do 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 do. Safe at last, do 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 do. Safe at last, do 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 do. Safe at last. It's the end, do 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 do. It's the end, do 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 do. It's the end, do 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 do. It's the end.
Luar biasa, tepuk tangan bagi kita semua. Silakan duduk dokter. Luar biasa, masih semangat di sore hari ini. Habis ini kita akan workshop. Jadi aliran darahnya dari ujung kaki ke ujung kepala, dari kepala ke ujung kaki lagi, seperti itu ya. Jadi perkenalkan, nama saya Vicky Valentino, yaitu adalah produk spesialis dari Optik Tunggal Sempurna, di mana kita pada hari ini ingin membedah keseluruhan dari mesin Oculus itu tersendiri. Jadi nanti kita akan memiliki 3 agenda. Yang pertama, saya ingin mengupas untuk visi dan misi PT Optik Tunggal. Lalu yang kedua, itu all Oculus device, all families, dari refractive surgery sampai nanti ke dry eye. Bahkan nanti ada myopia management. Lalu yang ketiga, ini all in one time. Jadi bagaimana kita mengimplementasikan kita tidak mau hanya mendapatkan nilai dan gambar saja. Untuk di tahun ini, karena masa depan sudah menanti kita membutuhkan AI atau artificial intelligence. Jadi sedikit singkat untuk background saya. Jadi untuk Oculus, saya mendapatkan titel expert di sini, expert untuk Oculus device application, dan melakukan training terakhir di tahun 2025 diagnostic training, dan sudah memiliki badges untuk Pentacam families, Pentacam OCT dengan Pentacam families-nya, beserta dengan myopia master, Corvis, dan keratograph 5M. Jadi ini ada beberapa sertifikat yang sudah saya lakukan, yaitu jadi untuk mesin-mesin terkait untuk Oculus. Jadi ada untuk optometris atau untuk keratograf di dalam kehidupan interpretasi sehari-hari. Sedikit singkat untuk visi dan misi PT Optik Tunggal, kita sudah berdiri sejak tahun 1929, yang dimana kita berdiri di awal mulanya itu di Cevilin OD, dan di mana sekarang itu kita memiliki head office tersendiri di Jalan Cikini Raya nomor 89. Di mana moto kami itu adalah best choice, best service, and best quality. Jadi Optik Tunggal has dedicated optical service in Indonesia almost 95 years per tahun ini, seperti itu. Jadi keseluruhan distribution market kita memiliki moto, yaitu adalah 48 jam respon hours policy. Jadi untuk rekan-rekan dokter yang sudah bekerja sama dengan Optik Tunggal, tentunya sudah mengetahui bagaimana service atau bagaimana quality daripada Optik Tunggal itu sendiri. Yang dimana ketika ada permasalahan atau ada beberapa komplain seperti itu, kita diwajibkan untuk memberikan respons kurang dari 48 jam dan memberikan responsnya kembali sebelum daripada 48 jam di seluruh coverage Indonesia. Moto kami adalah best choice, best service, and best quality. Dan Optik Tunggal, selain distribution networknya, kita juga berkomitmen untuk memberikan produk terbaik di ranah ophthalmologis. Dan di sini sudah kita lakukan demo-demo di beberapa tempat. Yang pertama adalah di daerah di Poli Diagnostic Tools, ataupun nanti yang di ruang OK. Kita berkewajiban untuk menemani dokternya kalau untuk operasi itu sebanyak 6 kali kunjungan, atau kalau misalnya dalam 1 minggu operasi kita wajib menemani 1 minggu operasi. Dan kalau misalnya di Poli juga kita harus memberikan service yang luar biasa untuk di perawat itu sendiri ataupun di dokter, yang dimana sudah kita lakukan. Ini ada social charity program dan training presentation, dan training presentation ini juga kita lakukan setiap ada kunjungan atau permintaan, yang dimana ini adalah contoh kasus customer training and support yang dimana sudah melakukan pembelian, namun ada pergantian terus menerus, yang dimana itu ada rolling di perawat, ataupun dokternya ingin di-refresh kembali untuk mengenai pentacam, mengenai Corvis, ataupun mengenai diagnostic tools yang lain, kita siap memberikan customer training and support. Yang dimana ini juga akan berimplementasi kepada pasien-pasien yang sudah yang mempercayai pada klinik tersebut. Dan tidak hanya itu, kita juga berkewajiban office group training, yang dimana kita juga yang sudah memiliki sertifikat itu tertentu, kita wajib memberikan ilmu itu kepada rekan-rekan yang lain, sales, produk spesialis, hingga nanti sampai ke perawat itu hingga bisa sampai kita lepas atau hands on. Dan ini adalah contoh kita wet lab. Jadi untuk para dokter ataupun sejawat yang lain ingin mencoba, di sini adalah contoh, memang di sini contohnya itu untuk retina, kita memberikan wet lab di kantor beserta dengan mesinnya, beserta dengan mikroskopnya, beserta dengan biomnya atau viewing sistemnya. Kita ingin memperlihatkan bagaimana mendapatkan feel yang bagus seperti itu. Dan kita juga berikan, jadi dokter tinggal datang saja untuk mata-mata ataupun bioniko ataupun mata-mata hewan yang lain, itu juga kita sediakan. Jadi dokter kalau menginginkan feel bagaimana cara beroperasi di retina ataupun di katarak, kita bisa berikan. Jadi dokter tinggal datang saja, make appointment dengan sales representatif kami ataupun saya pribadi, lalu kita akan buatkan arrangement untuk melakukan wet lab atau dry lab seperti ini. Jadi ini adalah Oculus training, jadi kita juga dilakukan training juga untuk semua Oculus produk yang lain, dan rekan-rekan yang lain juga harus mengimplementasikan kepada yang lain. Seperti itu, jadi tidak hanya mesinnya saja, tetapi lebih ke trial frame ataupun yang lainnya. Yang pertama yang sudah dikupas tuntas dari Dr. Brendan, ada Dr. Gary Kundo dan Dr. Christina Tan dan dengan beberapa panelis. Di sini saya akan menyampaikan bahwa dari Pentacam Families itu sudah menjadi gold standard. Dan gold standard ini kita tidak hanya memberikan nilai topografinya sekian. Kita tidak bisa dari Oculus tidak hanya memberikan K1 dan K2-nya 41, 42. Kita masih terlalu jadi kita inginkan artificial intelligence ini bisa diimplementasikan biar jadi make decision maker yang sangat tepat. Jadi dari tahun 2002 Oculus Pentacam ini yang pertama itu ada Oculus Pentacam Basic, tapi tidak saya tampilkan di sini. Jadi yang basic itu untuk beneran tidak ada beberapa klasifikasi lasik untuk programnya. Namun di sini ada Oculus Pentacam HR. Oculus Pentacam HR ini sangat cukup untuk dokter-dokter yang ingin melakukan refractive surgery. Jadi ini sudah tersedia untuk Belin Ambrosio, untuk keratoconus staging, menggunakan Oculus Pentacam HR pun sudah cukup. Untuk Oculus Pentacam AXL yang di sebelah kiri, yaitu untuk ada biometrinya. Jadi yang sudah dijelaskan oleh Dr. Christina Tan itu ada pemilihan IOLs-nya, seberapa angle kapanya. Kenapa kita menggunakan Pentacam? Karena Pentacam menggunakan skim flux. Skim flux itu tidak terpengaruh oleh dry eye. Di mana kalau dry eye itu ada di kornea, pasti akan mengubah nilai K1 dan K2. Nilai astignya pasti berbeda. Nanti akan membedakan nilai di IOL torics, delta K atau yang lainnya seperti itu. Yang ketiga ada Pentacam Axial Wave. Axial Wave ini adalah tomografi with biometry with wavefront analyzer. Wavefront analyzer itu untuk memperlihatkan ada pasien datang ngeluh ngeblur seperti itu. Jadi bisa memetakan yang bermasalah itu di kornea kah atau di lensanya. Kita make decision makernya di mana? Kalau misalnya kita pasien datang ternyata pasiennya katarak, kita sudah lasik, jadi untuk kepercayaan trust daripada pasien seperti dipermainkan seperti itu. Jadi kita sudah bisa menyediakan di Oculus Pentacam Axial Wave itu dipetakan secara keseluruhan. Dan yang terbaru di sini adalah Oculus Pentacam Cornea OCT, yang dimana ini memetakan kasus-kasus corneal scar, cornea edema, untuk kasus-kasus implan kornea itu bisa dilihat oleh menggunakan cornea OCT ini. Jadi daily changes sebagai kita itu apa sih? 20/20 itu bukan goal yang pasti. Yang dimana itu kita harus menaikkan increasing daripada patient volume. Tentunya kita butuh income yang banyak, tidak hanya dengan mesin-mesin yang superior seperti itu. Dan lalu yang kedua kita harus memperlihatkan early disease detection. Apa yang salah pada mata pasien ini. Dan integrasi daripada teknologi terkait dan memberikan kompleks managing dan patient education, dan yang terakhir adalah workflow-nya. Setelah itu apa? Yang kita tahu untuk di Indonesia ini sudah mulai kereta cepat. Kereta cepat Indonesia Cina itu adalah kereta yang cepat dari Jakarta dan Bandung. Kita membutuhkan waktu yang sangat cepat, tepat dan nyaman, di mana kita bisa make decision maker dan kita bisa tidak waste time di situ. Apakah yang harus kita lakukan ketika kita lakukan single capture, kita dapat semua, nggak usah satu persatu. Ini adalah contoh tampilan terkait yang dimana pojok kiri ada beberapa tampilan topografi yang dimana kita sebagai rekan-rekan sejawat dokter pasti sudah familiar dengan topografi. Lalu pertanyaannya apa yang harus dilakukan? Ketika kita mendapatkan nilai topografinya K1 dan K2-nya 41 dan 42, what next? Lalu kita mendapatkan OCT yang luar biasa dengan angle yang luar biasa, tetapi kita mengukur chambernya itu secara manual, apa yang harus dilakukan? Ketika kita menggunakan mesin-mesin wavefront, mendapatkan nilai Sperry, cylinder, and axis, apa yang harus dilakukan terlebih dahulu? Dan kalau kita mendapatkan nilai topografi yang tidak sampai ke perifer, apalagi untuk kasus-kasus ortoke, kita membutuhkan sampai ke 12 mm kornea, apa yang dilakukan? Jadi Oculus ingin meminimalisir ketika kita membeli mesin yang banyak, tetapi kita tidak bisa mengintegrasikan dengan cukup baik. Dengan banyak mesin di banyak poli, tetapi tidak ada decision maker-nya, jadi pasien juga merasa lelah untuk capture. Jadi ada waktu yang terbuang di situ. What's next seperti itu. Di sini kita tampilkan yaitu pentacam axial wave yang sudah dipresentasikan oleh Dr. Brendan Konin, di mana di sini bisa memetakan totalnya kita bisa adjust untuk abrasinya kita bisa adjust juga optical zone-nya. Kalau optical zone-nya kita berubah, ini yang didapatkan oleh pasien. Yang didapatkan oleh pasien dari korneanya dan dari internalnya juga akan mengikuti. Dan di sini juga koreksinya itu bisa dikoreksi, silindernya bisa terkoreksi, ataupun yang corrected, ataupun yang uncorrected. Jadi kita bisa mengetahui kondisi real pada pasien itu seperti apa. Sudah memiliki refraksi, dan sudah memiliki review artikel terkait. Kalau misalnya kita mendapatkan mesin tetapi tidak ada basic study yang mendukung, jadi kita tidak confident untuk melakukan itu pada pasien tentunya. Dan ini sudah dilakukan oleh dokter autor kita yaitu Komo Safini, ada beberapa case reportnya untuk mendukung di mana pentacam ini beneran untuk gold standard pada pasien itu sendiri. Dan tidak hanya itu, pada setiap tampilan displaynya, Oculus itu memberikan literatur, tidak hanya nilai omong kosong, K1 dan K2-nya dari mana. Contoh di sini adalah BAD, Berlin Ambrosio Enhanced Ectasia Display, didapatkan nilainya 9,5. Nilai 9,5-nya itu dari mana ya? Ketika kita ingin melakukan research ulang, kita tanya kepada sales yang bersangkutan, tidak bisa mengetahui nilai-nilai terkait, ketika kita tinggal klik literatur, langsung didapatkan semua nilai, standar nilai value kita mendapatkan 9,5 dari mana. Kita tidak mencontek dari beberapa mesin yang lain, Oculus memiliki nilai tersendiri untuk mendapatkan superior seperti ini. Jadi contoh kembali lagi, di sini adalah ABCD keratokonus staging. Bagaimana kita memanage keratokonus staging, dari mana nilainya, TKC-nya berapa. Dan jangan khawatir, masing-masing pentacam itu ada segitiga kuningnya. Ketika kita klik segitiga kuningnya, langsung tertera buku terkait yang dimana nilainya itu dari mana. Jadi sudah tersedia literatur yang digunakan. Literatur yang digunakan seperti ini. Jadi untuk penelitian pun kita sangat support. Jadi kalau misalnya ada dokter yang ingin melakukan penelitian, contoh ingin melakukan penelitian miopia manajemen menggunakan ortoke ataupun atropin, bagaimana efek kornea pada atropin, jadi nanti kita bisa bantu dokter, kita make arrangement, kita bisa lakukan paper yang ada seperti itu. Ini adalah mesin terbaru yaitu pentacam corneal OCT yang dimana kita bisa memperlihatkan, ini adalah contoh corneal scar, dimana itu bisa memperlihatkan seberapa dalam. Ini contohnya, dan ini yang didapat. Corneal scar-nya itu sampai berapa dalam, berapa mikron. di mana itu sudah masuk ke bowman layer dan sini sangat mengganggu seperti itu. Dan ini adalah contoh map dot fingerprint yang dimana kita sudah kita lihat di sini ketika kita lakukan zoom tidak pecah untuk OCT anteriornya. Jadi kita bisa memperlihatkan seberapa dalam scar daripada kornea pasien itu sendiri. Dan yang unik lagi, OCT pada pentacam itu menggunakan wide angle pericentric scan. Jadi OCT-nya itu berputar. Jadi bisa memperlihatkan sampai ke daerah perifer sekalipun sehingga miring. Ini adalah hasil epithelium map, yang sebelah kiri itu adalah contoh kasus postmyopic epithelium map. Yang di tengah itu adalah contoh kasus hyperoplastic dan sini adalah estetik keratokonik seperti itu. Dan yang kedua, tentu pentacam ada pasangannya itu adalah Corvis ST, di mana ini adalah 2-in-1 machine untuk glaucoma dan untuk refractive cases. Jadi glaucoma properties with biomechanic properties, jadi ini adalah basicnya NCT atau non-contact tonometry yang memiliki light source dan diterima oleh fotosensor. Yang dimana untuk melihat biomekanik pada pasien itu akan berpengaruh dengan fibrosis limona yang di darah pada sklera. Kalau misalnya stiff sklera, itu kita bisa melihat lamina fibrosis pada skleranya juga ikut keras seperti itu. Dan tidak hanya itu, untuk keratokonus pada oculus pentacam ini itu memiliki database yang sangat besar, yang dimana itu memiliki database hingga 4.000 pasien keratokonus dengan kasus 1.000 pasien fras keratokonus dengan 3.170 pasien sudah termeasure di sini. Jadi kita tidak memberikan nilai omong kosong yang ini nilainya 12,5, 14, 15, tetapi kita ada database pasiennya. Dan di sini juga yang menarik di sini adalah sudah dilakukan studi grup oleh International Corneal Biomechanics, yang tentunya kita mengetahui beberapa nama di atas, ada Prof. Rohit Sethi, ada Prof. Renato Ambrosio untuk melakukan studi grup untuk biomechanics pada Corvis ST. Jadi kita memberikan nilai yang pasti dan nilai yang sudah teruji seperti itu. Jadi 10 years evolution, early ectatic detection, jadi itu kita bisa melihat, jadi untuk versi yang pertama dan versi yang kedua kita tambahkan nilai prosentasenya. Jadi ini nilai prosentasenya itu hingga 98,4% dengan sensitivity 96,8% dan spesifiknya 98,3%. Jadi ini adalah yang diberikan refractive toolbox oleh Profesor Ambrosio Visionary Guidance for the Solution Ideal. Ketika nilai TBI-nya kurang dari 0,4 diperbolehkan untuk menggunakan LASIK, SMILE, PRK, TPRK, ICL. Ketika nilainya 0,4 hingga 0,5 itu diperbolehkan PRK, TPRK, or ICL. Ketika nilainya 0,5 disarankan untuk ICL dan lebih dari 0,5 kita disarankan untuk observasi terlebih dahulu. AI seperti ini yang kita butuhkan, tidak hanya memberikan nilai K1 dan K2, pekimetrinya berapa, nanti PTA, RST-nya berapa, namun kita bisa ada decision maker-nya, ada decision planner-nya, apa yang harus kita perbuat, seperti itu. Lalu yang kedua, untuk Corvis ST, untuk pasien-pasien yang sudah pernah melakukan LVC, pasti akan otomatis muncul pesan seperti ini. Post confirm, post PRK, post LASIK, post SMILE, post LVC, or no LVC. Yang dimana tentu saja database-nya sudah East Asian. Yang dimana ini sangat langka terjadi, di mana mesin-mesin diagnostik tools itu jarang menggunakan database orang Asia, tetapi di Oculus itu menggunakan East Asian database. Lalu yang ketiga itu ada AI untuk mempresentasikan elevasi pada kornea, di mana mendapatkan nilai total D. Kalau total D-nya seperti ini sudah kuning, tidak disarankan untuk melakukan SMILE seperti itu. Dan untuk keratokonus staging-nya ada A2, B4, C2, dan D1. Kelebihannya itu ada kita bisa memetakan layer per layer. Dan kita di sini bisa mengarrange apakah operasi kita berhasil atau enggak. Ini adalah contoh yang dimana pasien sudah dilakukan cornea cross-linking di tanggal 9 bulan 12 tahun 2012 ya di sini. Jadi yang di awal pemeriksaan itu di tanggal 20 bulan 7, 22 bulan 8 lalu dilakukan treatment cornea cross-linking. Kita bisa memperlihatkan klasifikasi pasien after operasi ini seperti apa. Jadi ini untuk guidance untuk sebelum dan sesudah operasi ini cukup luar biasa terlihat seperti itu. Di mana ketika ilmu pengetahuan dan ditambah dengan manajemen waktu yang sangat luar biasa, income pada pada rumah sakit tentunya lebih banyak seperti itu. Ini yang kita butuhkan, make decision maker-nya ada, kita mengurangi waktu, pasien lebih banyak datang, dan trust pada pasien kepada kita tuh lebih percaya seperti itu. Lalu yang ada beberapa mesin yaitu adalah dry eye tools, yaitu sebelum kita melakukan operasi yang ada, kita harus melakukan assessment pada tear film karena ocular disease itu bisa menyebabkan beberapa refractive surprise atau IOL exchange seperti itu. Jadi tear film analysis ini sangat esensial sebelum daripada operasi. Lalu yang menarik di sini adalah AI pada myopia management yang dimana kita bisa memperlihatkan pasien umur 12 tahun, kita bisa memperlihatkan ketika nanti pasien tidak dilakukan treatment, kurvanya bisa naik ke atas. Ini lebih ke simulasi pada pasien. Yang dimana BHVI ini adalah suatu AI yang sudah bekerja sama dengan Shanghai University untuk memperlihatkan pasien-pasien anak Asia yang dimana di tahun 2050 nanti akan menaik drastis hingga 50%. Jadi kita bisa lakukan treatment planner. Nah, treatment plannernya bagaimana? Kapan kita pakai atropin, kapan kita pakai lensa, itu kita bisa lakukan di assessment pada GRACE ini. Ketika nanti nilai korneanya lebih besar daripada biometrinya yang menyebabkan anak ini high myopic, kita bisa suggest ke orang tuanya cukup menggunakan kacamata plus atropin ataupun lebih ke ortho K lens. Kalau misalnya Axel kita lebih ke atropinnya kita lebih besar karena inilah contoh kita tidak hanya memberikan nilai tapi kita memberikan value kepada dokter dan pada pasien di mana kita ini bisa memberikan trust yang luar biasa pada pasien. Oculus perimetry sudah juga kita memiliki beberapa varian yang dimana ini memiliki sistem seperti SITA yaitu adalah Spark yang dimana cukup waktu 3 menit kita bisa melihat assessment keseluruhan pada luas pandang mata pasien. Lalu yang menarik di sini adalah visual test equipment di mana sebelah kiri saya sebelah kanan saya itu adalah Oculus binoptometer itu memperlihatkan visus pasien after operasi. Yang dimana kalau misalnya pasien-pasien yang after operasi multifocal IOLs kita susah mendapatkan visus-visus terbaiknya ketika dia lurus ataupun membaca. Kalau untuk binoptometer ini bisa memperlihatkan nilai visusnya berapa, 20 per berapa, di sudut dia membaca, ataupun dia sedang naik mobil seperti itu. Terlihat semua. Jadi kalau yang kedua ini AMC anomaloscope, ini untuk memperlihatkan tes buta warna. Tes buta warna ini berbeda seperti isi garat tes. Jadi bisa memperlihatkan ketika warna biru dan warna hijau bersatu dia memberikan berapa persentasenya. Dan mesotest ini adalah untuk memperlihatkan sensitivitas glare dan kontras dan sikuan itu adalah untuk memperlihatkan kontras sensitivity-nya. Jadi clinical kategorisnya yang didapatkan pada kehidupan sehari-hari kita membutuhkan contact lens fitting, refraksi, myopia management, corneal management, refractive surgery, glaucoma management, dan retina management. Bagaimana kita mendapatkan seluruhan informasi ini dengan cepat, tepat, dan make decision planner-nya lebih baik. Di mana kita akan masuk ke agenda all in one time, di mana kita bekerja sama dengan Optos, yaitu kita bisa mengcombine nilai daripada Oculus dan Optos ini untuk memperlihatkan kalau misalnya di anteriornya ada masalah, kita harus wajib memperlihatkan dari posterior daripada pasien, combine in the future. Jadi kalau misalnya fundus imaging ini adalah memperlihatkan retinal health pada pasien sebelum dilakukan operasi LASIK ataupun SMILE. Di sini adalah contoh penggambarannya, ini hanya satu single capture untuk mendapatkan 200 derajat, seperti itu. Jadi ini adalah contoh yang sudah saya lakukan di Rumah Sakit Mata Cicendo. Ini adalah mata anak umur 3 bulan, kita hanya dibedong saja, tidak usah tiduran, tidak usah masuk ke kamar operasi, tidak usah dianestesi lebih lanjut, kita hanya cukup ruang poli saja, kita tinggal bantu anak untuk memperlihatkan. Kalau misalnya kita tidak bisa bantu membuka mata, kita cukup menggunakan spekulum bayi itu cukup. Jadi ini kita hanya lakukan di poli dan yang menarik adalah hanya 2 detik hanya 2 detik untuk mendapatkan nilai 200 derajat retinal imaging dan kita lihat di daerah perifer itu sudah melakukan adanya traksi pada retina itu sendiri. Dan ini adalah contoh penggambaran peripheral di retinal degenerasi, di mana kita bisa menjadi superior di anterior dan juga kita menjadi superior di daerah posterior. Jadi kita bisa memperlihatkan depan dan pada dan syaraf pada mata pasien. Kita bisa melihat sangat susah untuk mendapatkan nilai mengklasifikasi bagian perifer pada mata pasien. Kita bisa melihat bahwa dalam satu single capture pada kasus retinal degenerasi kita bisa melihatnya dengan secara luas, tidak membutuhkan lihat kanan kiri, kita langsung bisa mengklasifikasinya. Sudah dilakukan beberapa studi di Takada Eye Clinic di Jepang, ketika menggunakan optos versus fundus kamera biasa, ini bisa menghemat waktu hingga ratusan menit. Karena untuk optos ini tidak dibutuhkan dilatasi dan untuk dilatasi tidak dibutuhkan. Nggak usah lihat kanan kiri ataupun atas bawah untuk memperlihatkan fiksasi pada pasien. Karena fiksasi yang menentukan adalah kita sendiri, seperti itu. Jadi bisa disimpulkan ketiga mesin superior ini kita bisa mengassessment kontak lens management, refractive surgery, glaucoma management, retina management, cornea management, myopia management, refraksi dengan waktu hanya 3 menit saja. Tidak hanya mendapatkan nilainya saja, tetapi kita bisa memanage apa yang harus kita lakukan. Percuma nilai ini hanya menjadi nilai, percuma nilai ini hanya menjadi angka, tetapi tidak ada make decision planner-nya, tidak didukung dengan basic SDM yang luar biasa. Jadi dengan waktu 3 menit saja kita bisa mendapatkan coverage dari anterior sampai posterior dengan ketiga mesin ini dengan luar biasa. Terima kasih waktu yang sudah diberikan, kami Optik Tunggal Sempurna berterima kasih untuk waktu yang sudah diberikan. Kami mohon maaf atas perlakuan kami mungkin dari tindakan atau kata-kata kami yang salah seperti itu. Saya pribadi membuka pertanyaan dan saya memohon maaf mewakili Optik Tunggal kalau misalnya ada beberapa pertanyaan yang diinginkan untuk beberapa mesin-mesin Oculus diagnostic tools lainnya, apa yang harus misalnya pengen demo, Mas kita pengen LASIK surgery tapi khusus smile aja. Nanti kita bisa arahkan mesin apa yang cocok untuk beberapa klinik tersebut. Tidak harus yang superior, tetapi kita menyesuaikan daripada dokter-dokter itu sendiri. Terima kasih. Selamat siang, salam sehat dan salam sehat seperti itu. Terima kasih.
Terima kasih Pak Vicky, boleh kita berikan tepuk tangan. Terima kasih untuk baby shark-nya ya Pak Vicky ya. Saya penasaran di rumah sepertinya punya balita ya Pak. Jadi hafal gerakannya dari baby shark. Baik, para dokter sekalian masih semangat? Luar biasa, baik. Jangan khawatir karena saat lagi Anda bisa menikmati coffee break. Dan yang pasti setelah coffee break, acara akan dilanjutkan dengan sesi hands-on dan juga workshop. Dan perlu para dokter ketahui bahwa sesi hands-on ini akan diadakan di ruangan vision di lantai 2 dan nanti peserta akan dibagi menjadi 3 kelompok dan nanti akan digilir untuk berada di satu stasiun ke stasiun berikutnya. Untuk setiap kelompok akan memiliki waktu hands-on 20 menit dan sebelum kemudian akan berpindah ke stasiun selanjutnya. Untuk daftar pembagian kelompok, para dokter sekalian akan ditampilkan selama coffee break. Nah, ini sudah ada di layar untuk grup 1. Silahkan boleh Anda cek apakah nama Anda ada di dalam layar atau di dalam table. Saya akan turun supaya tidak menghalangi pandangan. Dan perlu diketahui juga para dokter sekalian, setelah sesi workshop dimohon untuk Anda bisa kembali ke Grand Ballroom, kembali ke ruangan ini ya, karena nanti akan ada pengumuman terakhir mengenai refractive weekend bersama dengan Optik Tunggal tentunya. Silahkan, ini untuk grup yang kedua. Dan ini untuk grup yang ketiga. Sekali lagi ini untuk grup 1, grup 2, dan juga grup 3. Sambil bergabung dengan grup atau kelompok Anda masing-masing, kami persilahkan ya para dokter sekalian untuk bisa kembali menikmati coffee break yang kedua. Dan tentunya jangan lupa setelah nanti Anda melakukan sesi yang selanjutnya, dimohon untuk bisa kembali ke Grand Ballroom karena akan ada pengumuman untuk agenda selanjutnya. Terima kasih.